So once you have accrued or randomized people and you're following the retention and attrition, what is the best way to think about keeping the participants in the trial? The ultimate goal is to have people cross that finish line. At the very least, you want to have a pre and post measure for every participant. So how can you ensure they will remain in your study? Well, the short answer is you can't. This is up to their dedication and their commitment. You cannot force or require a participant to remain in your clinical trial. However, there are certainly ways that you can encourage people to stay. It does take a team effort. It starts with your protocol. Make sure that you simplify your protocol to the best of your ability. Simplify the intervention, simplify the data collected, and simplify the intervention. That's in there twice, and there's a reason for that. If this is arduous for participants, they are likely to leave. So think about if they are taking 17 pills in a week, there's something called pill fatigue. If they're taking daily injections, there's something called injection fatigue. Now, you can't do anything about that if that's the way that your intervention is formulated. However, you can simplify the rest of your study. So to remove the participant burden as much as you can. You want to simplify the visit schedule. You want to make sure that you're only collecting the data that is required. And again, you want to streamline the visits to reduce that participant burden. So when you're thinking about screening the participants, you really only want to randomize participants that you have a reasonable belief will complete the study. A thorough screening of participants will help limit randomization to those that are dedicated to the entire trial. That means you need to be very clear about trial expectations during the informed consent process. A lot of people will roll their eyes at how complicated the informed consent process has become. There are now new streamlined ways. So there's something called e-consent, where participants can watch videos and answer questions about the study so that you can ensure that they understand what they are essentially signing up for. You can shorten the time from screening to randomization. That alleviates the need for people to come back for a second visit or a third visit, if possible. However, screening and randomization on the same day also allows for people who started the intervention to change their mind. So some time spent between screening and randomization allows for patients who would be very dedicated to completion of the trial to really think it through. So if you're doing the informed consent process very early on screening, which you should, in order to screen a participant, you have to consent them first. Make sure that it's not screened and then immediately randomized. Make sure you have time to do all of your baseline data collection before you introduce the intervention. That will give that participant at least some time to really consider whether or not they want to start the intervention. Make sure your sites are ready to go. You don't want to start the screening process if the intervention is not at the center. You don't want to start the screening process if you don't have all the materials that you need for behavioral intervention. You don't want to start the screening process if you don't have all of the instruments needed for a surgical intervention. The last thing you want is to have people screened and excited to start a study in February, but tell them that they can't be randomized until August. You will likely lose a large percentage of those participants. In addition, their concomitant or confounding variables or eligibility criteria may have changed after that lengthy period of time. You would then have to rescreen them, and that's unfortunate because a lot of people would decline simply based on that. Before a participant leaves the clinic after their initial visit, make sure that you have visits scheduled before they leave so that they know what the expectations are of when they are returning. Make sure you call them, make sure you email them, make sure you text them, make sure you contact them through a study website. So you want to streamline the screening process and make sure that people understand what it is that they are signing up for in this study and have them ready to participate with everything that they may need. Then you move into follow-up. Shorter follow-up helps keep track of participants with current contact information. If this is a chronic long-term disease, you may be looking at a 3, 4, 5 year, 7, 10-year study. That's okay. Just make sure that you don't go a year without talking to a participant. Now, it certainly is easier to find people these days, but you still have to consent them to be able to find them. So make sure that you have contact information. Make sure that you have backup contact information. Make sure that they know how to contact you. So magnets for their refrigerator, stickers on their diary if they're doing a patient or participant diary. Make sure that the phone numbers, website, email addresses are all readily available to them so that they can let you know. If you are going longer periods of time without seeing a participant, or if you're never seeing the participant, make sure that you have contact with them at regular intervals so that if they move or they want to decline the study, that you know why. It is incredibly important to capture loss information. So set up a calendar so the trial team can see when people are expected and follow up quickly on any missed visits. You need to send certified letters to make sure that they are returned with a signature. In those letters, you may actually have an exit form so they can tell you a little bit more information about why they are terminating the trial. In addition, if they don't want to participate in the study anymore, potentially ask them if it's a 3-year follow-up. At year 3, they would be willing to come back in and be assessed. That way, you still have data on them at the time that they should have had a termination visit. You'd be surprised at how willing people are to continue in your study if you are a little bit flexible. Remember, getting data is better than having missing data. So really have a conversation with your participant about how you can keep them in the study. If they're taking a new intervention, often pregnancy will require that women stop an intervention, but continue to follow up. Have them come into the clinic, have them do whatever data collection that they can do, even off the intervention. Remember, if you're doing intention to treat, they'll be analyzed in the arm they were randomized to, regardless of whether or not they took the intervention or participated in the intervention. So having the data is always better than not having the data. Oftentimes, if they, at the completion of a pregnancy, or if the pregnancy ends, or if they stop breastfeeding, those participants are allowed to begin the intervention again. Same thing if people have a concomitant illness that interrupts the trial. So let's say they have an accident, they break a leg, they have to have surgery, they get cancer and they have to have surgery, they have to stop for chemotherapy. If the trial duration is long enough, or if they can simply stop the trial intervention, you may still be able to measure the endpoint on those people. That data will come in incredibly handy later when you're looking at all the different variations of data sets besides intention to treat, and including intention to treat. If you have data, you don't have to worry about missing data. In your follow-up, make sure that you have shorter visits. Shorter visits lower participant burden. They're more likely to return. Be flexible on your visit windows. So 3 months, and keep in mind, are you talking days or calendar months? Those are two very different things. Your computer programmers will often tell you they need a day count rather than a calendar count. If they're due in December 1st, is it possible that they come in before Thanksgiving? If they're due in December 24th, could they come in after New Year's? So be as flexible as you can. Plus or minus 1 week or plus or minus 2 weeks is often acceptable. If you're doing an annual visit, so if you see somebody at baseline at month 6, at year 1, and at year 2, can that year 2 be plus or minus a month? So be flexible on visit windows and try to get every participant that you can into the clinic. If they refuse to come in, will they fill out some of the data via the phone? Can you offer them a website to complete the participant reported outcomes? Can you mail it to them? So every effort should be made to collect some data on every participant as long as you can. Remuneration is an interesting concept. So this is payment of your participants. And this can be useful, but it's not always possible. Some institutions and some funding agencies flat out forbid it. Others will allow payment to cover costs of travel, parking, missed time at work, or small gift cards. If you need to travel to a remote center like a VA facility or a specialized hospital, then housing and travel is often covered in the budget, and that is okay. Maybe food, maybe their time, similar to the concept of jury duty. Where you may be paid for your time, but certainly not in a sufficient manner that would entice you to participate in the study. So be careful about offering Be careful about offering remuneration, or payment, and check with all applicable funding agencies in your institution about what the guidelines are on how to do that.